Good morning. Good morning to all of you and Dr. Mattu, Dr. Swamikan and Dr. Sachdev are actual main supporters from the government side, and also now Dr. Sachdev is doing something else, but he's been one of the most committed officers of the government of India to actually catapult the TB effort to a more sort of encouraging level where we could say that there are certain points where we can do what our Prime Minister promised. So as you know, there is a UN goal of TB free world by 2030, and our Prime Minister, Mr. Modi, of course, upstaged it and said we will get rid of TB from India by 25. So sitting in 23, we really have to wonder how far along we are and what we can do to actually accomplish it. So bringing into our interest from Vedanta in TB was the most remote thought in my mind. But our warriors, led by Dr. Morali Datta and then guided now by Dr. Jaiswal, who have both jumped in with both hands and feet, they have really done a great job in at least Haryana, and now ambitious to expand it to other states. But I was thinking this morning that, we need to actually find champions for every state, and maybe they are, which I'm not aware of. I mean, I'm sure there are many, many people around the country who are working, and we should actually figure out, because I don't know, maybe you guys know, and maybe the people in the union know, and thank you for all your support. The union and the USAID and the US Embassy, all these people have jumped in to help with this pledge. But the point basically is, what can we do actually to accelerate it in a more focused form? Because we've done a lot of work in the last 5 years to understand the ground realities. Of course, in Haryana, we have learned many lessons from Vedanta and the government's guidance. But at the same time, we don't know where this ocean is actually still churning, and we don't know what we need to do about it. And I think at the end of this deliberation, if it could be understood, at least for people like me, that where are we, what are the gaps, and should we not actually make that like on war footing to accomplish as much as we can. Maybe we can lick it by 25, I'm not sure, but I would love to understand that yes, we are way along. So whatever we need to do, we should actually refocus on it and say, these are the interventions that we can do, because the government has a very, very active program. Wherever we, for our social responsibility from the private sector, whether it's industry or whether it's healthcare facilities, we can all do a lot. So now I was just thinking this morning as I woke up that I'll speak to the Haryana Chief Ministers to say at least we should make Haryana TB free by 25 and see what plan we make today. Okay, so let's see your guidance, and we'll have to make a real proper sort of rolling forward plan where we're like basically going to war. And we should have all our ammunition and Army, Navy, Air Force together on this to see if we can accomplish it. So you might well do that, because we are doing a lot of things in a more sort of scattered form. If we refocus, maybe we can accomplish something. So with that, have a good day's deliberation, and I want to thank again our supporters. There are many supporters from the industry, from PSUs, from the government, from international agencies, the union especially, which is always pressing on our tail, which is great. Thank you for doing that. And USAID. So thank you for being here, and I'm the least knowledgeable, so let the knowledgeable people take over. Thank you very much.
Inspired us with his tireless work against TB, initially as DTG of the Central TB Division and now in the Union.
Thanks, Monali. Dignitaries on dais, Dr. Trehan, Ruben Swamikan, Dr. Ruben Swamikan, Dr. Sanjay Kumar Mattu. Off the dais, Anand Jaiswal, Monali, Professor Andrew, Professor L. Story, Dr. Bhavin, other dignitaries of the dais. I think it's the way Dr. Naresh Trehan is leading this initiative, and he has prompted Rajesh to say that we must try to achieve 2020 TB elimination at least in Haryana by 2025 is very motivating and inspiring. Having said that, the engagement of corporate sector and engagement of sector beyond so-called public health sector has been very encouraging journey under TB elimination program. So Dr. Trehan, what we have seen is from 2,000 patients notified in 2012 from the private sector. Last year it was 7,20,000 or something from the private sector. Huge applause to all those who are supporting the program to reaching that target, and you are one of the leaders in that fight. I also recall sometimes when I was there at the government, we had sort of entrusted you with the responsibility to lead engagement of other corporates beyond Medanta and take it forward. And again, I'm taking this opportunity, I'm not sure where that reached, but the presence of ministry officials, I'm again reiterating that we need to have leaders and influencers like Dr. Trehan who can actually lead a more meaningful engagement of at least corporate sector within the medical realm, the corporate hospitals and other influencers. I also feel, Dr. Sanjay, that, and if Bhavin may recall, that we had a medical task force on medical colleges. And we once decided that we'll include all DMB institutions within the realm of medical college task force. In fact, your chairperson of NTF at that point of time, Dr. Behra, was leading an institution which was a DNB institution. It was a National Respiratory Institution, is another fact, but they were not having a sort of a university affiliation at that time, and they were affiliated with the Diplomat National, but they were a DNB institution. So again, high time again to get them into the fold. Now even the PG entrance examination, you don't distinguish between MDMS and DNB candidates. So I think for us to do that at the national program level is not fair to the contribution that they make and the potential contribution that they can make. So from increasing notification from here on, I think we need to get them on board. So again, this is for advocacy to Sanjay and DDG who's present virtually, and also all those present here. So having said that, I've seen the work of Medanta, Dr. Bernali, Dr. Jaiswal in the field, and I'm quite impressed with the way you have taken up that active case finding supported by colleagues from the UK. And we would actually like to see that if Dr. Ajit can expand it to a population level screening in the entire Haryana. Haryana is where it's a low-hanging fruit for you, where you can show some results. So we would be willing to walk that extra mile and see if we can mobilize resources and take it to that level. Also, when we talk of TB elimination, I think moving country from a high burden to a low burden should be the first benchmark which we should be trying to achieve, and that we should do very quickly. So again, an appeal to all of you that let's try to do that very quickly. We can demonstrate at least that from a high burden we move to get out of that 27 high burden countries, which will be a low hanging fruit. So getting out of that 27 notorious list will be a low hanging fruit. So we should all aspire for that. And I think led by our partners, we will be able to do that. Thank you very much for your attention. And
good morning. Thank you, Dr. Bernali, and respected dignitaries on the dais, and colleagues, friends, and other dignitaries of the dais. It's an absolute pleasure to be here today and be a part of this event. So, just to draw some inspiration and a few memories, I think it was 2014, Dr. Trehan, when we actually met in Mumbai, and the legendary actor Mr. Amitabh Bachchan was there, and he actually spoke on TV, and I think part of the inspiration for Dr. Trehan was there, and he hasn't left the flag down since then. Dr. Trehan has been holding the flag up for TB, despite him not having that experience, but he has continued to support this cause and support this effort, and he's actually led the way to say that there are solutions in the private sector and the corporate world that can help India reach its goal of TB elimination. I think over the years, it's transformed. Dr. Sachdeva mentioned how the numbers have increased dramatically in the private sector in terms of notification, but also over the last few years, the corporate TB pledge that is being run by the union, that is now over 300 people strong, 300 corporates strong, and I think yesterday we just had a kind of a brief on what the corporates can bring to the table. It's amazing the kind of inputs that they have, the kind of reach, the capacity that's available to be able to provide solutions. So I think the government is doing its bit, and both Dr. Mattu and Dr. Joshi are online, and they will speak to that. But I think for the rest of us who are outside of the government, this is a great opportunity to be able to stand up and state your cause in support of what can be done. I think also we have a number of examples moving forward in the state of Haryana itself, and Dr. Raju, the state TB officer, is testimony to how we've been able to, say for example, in hard to reach, difficult district like Hisar, where we're actually able to transform the utilization of the private sector in enabling services to the last mile. So I think it's not just about the urban population and the urban spaces where the corporates can help. They're also willing to move into the rural, difficult to reach, and provide services in areas where it's most needed.
On behalf of Central TB Division, I'm very happy to be part of this very important aspect of corporate hospitals joining with National TB program beyond the notification. And it is only due to the efforts of all involved partners, private hospitals, private care providers, and community that we can achieve the goal. In this, the role of the private practitioners and the hospitals is twofold. One is to notify all the tuberculosis cases which they have detected and they are treating, so that we can do the public health action on those patients, whether it is looking after their household contacts, screening them, giving TB preventive therapy, looking at the clusters, giving them the benefits which the government is giving to a TB patient. That is one part. But I'm very happy that there are hospitals like Medanta, Yashoda and others which have gone beyond this. They are supporting the National Tuberculosis Elimination Program with many innovative ideas which are going to help a lot in the community. So on behalf of Central TB Division, I'm very happy to note these best practices, and I'm sure these best practices, which it spreads across India, it will definitely make a real difference in the tuberculosis management. So I congratulate all the corporate hospitals which are supporting us in this endeavor, and I wish this function all the very best.
very key partners are the state and the district. Dr. Simi Kapoor is the district TB officer of Karnal, where we have been currently working, and she has been tremendously supportive, both her and her team. I don't think she's present today. Dr. Rajesh Raju, we all know, the state TB officer of Haryana, who has backed up the entire program. So may I request Dr. Raju to come on stage and accept a token from Dr. Trehan. Mr. Mohammed, close on the heels. May I request Ms. Srija Nair, also from the union. A lot of work runs the entire program on the ground, and we are really grateful for all the hard work.
It's because of us that you're stuck.
And finally, I invite Mr.
So just the fact that there are so many of you who are supporting this program here and making it possible for all of us to work together towards our common goal. It is a big enemy, so hopefully we'll lick it.
Okay.
All of us know the private healthcare sector is quite vibrant in the country. National Sample Survey Organization always tells that almost 70% of the patients seek care first in the private sector, right? So we all know that, and to cover these people who are seeking care in the private sector, it's very, very important that we engage the hospitals, clinics, pharmacies and laboratories. I'm sure the TB team at the central level also agrees that when we analyze the data from the notification, the highest number of the patients who are notified are still from the hospitals and the multi-speciality centers as compared to the clinics, laboratories and pharmacies. So the notification progress has moved a little bit, I would say, and there is a moderate success over there. While we are gathering today to understand from the audience and from the respected panelists about how to take it forward from not just from notification but beyond. So to set the context, I would request first of our speaker is Dr. Sanjay Mattu, Additional Deputy Director General of Tuberculosis at Central TB Division, Government of India. Dr. Mattu has a vast experience of public health programs and operations in tuberculosis. Particularly, he has handled the NICSHE, which is globally known information management system of tuberculosis, the direct benefit transfer scheme, which is widely acclaimed. He is currently handling the portfolio of corporate sector engagement, TB comorbidities, and in the past he has worked for public-private partnerships, the logistics management, which is so crucial to the entire operation. So with such a wide experience from our eminent speaker, now he will.
So basically, nowadays we are moving through a historic time. In earlier days, like when I was doing my graduations in medical school, it was told that whenever in India we are thinking of any symptoms or so, tuberculosis was the first and the foremost differential diagnosis. And now time has come when we are thinking of that we want to end tuberculosis globally, not only from a single country, but we want to end it from a global situation. And how it is happening, basically we are having a very good innovations are there, and technologies are there, and we are having the partners who are supporting in this particular coach. So I am having the brief presentation where we are having a programmatic setup, how the program is moving, and what are the corporate sectors and the corporate hospitals role when we are looking for this larger coach. Continue as a major public health problems, and in this regard, when we are moving towards this, we are having the greater and the highest commitment from the government, and the political commitment is there. There has been the clarion call from our Honorable Prime Minister, where he has thrust the task for this NTB targets. There has been another event in October 9th October 2022, when our Honorable President had a launch of the program. We called it a Pradhan Mantri TB Mukt Bharat Abhiyan, where we requested communities, organizations, NGOs to come forward and adopt the TB patients. When we are saying the adopt the TB patients, we want to reduce the stigma. If some persons are having the ability to provide some nutrition, so that is another aspect, that some nutrition supplement may be given. Program is already providing some monetary incentive to the TB patients. We are giving Indian national rupees 500 per month. Along with that, we can this community may also come forward to support in addition to what the program is already doing to these TB patients. And in program we are having nowadays a better technology are there when we are having this diagnostics and the treatment facilities. Next slides will. We are having a situation in India. It is almost every fourth tuberculosis patient is from India. We have progressed very well, but still it is a very big problem in India. And 83% of the tuberculosis cases come from the most of the productive age group. It is also affecting the country's economic condition, because it is affecting the most productive age group. And as I mentioned that almost 1/3 of the mortality from tuberculosis when we are seeing the world situation is from India, and almost 28 to 25% of the global TB burden is contributed from India. Some of the laboratory infrastructures, and it is expanding from a peripheral level to the national level. We are having a national reference laboratory, then at the state level we are having the intermediate reference laboratories, we are having CDST laboratories are there, and program is now moving from this microscopic testing to have this nuclear acid amplification testing, which is basically molecular diagnostic test to identify the DNA of the bacteria, and so we are having this upfront tech. Whenever we are having this case has been identified, we want to put the patients promptly on the right treatment, and appropriate regimen is to be followed. And we are having the STCI guidelines, the Standards Care for Tuberculosis in India is a guidance book which is providing all kind of details how the patient need to be put on the treatment. And basically we are having the patient-centric approach is there. Instead of that patient has to have more effort to avail these services, we are trying to provide the services nearby to the patient's residence, and all the concerns of the patients are being addressed. We are providing this fixed dose combination so that pill burden may be reduced. We are having appropriate regimen which are followed world over and has been recommended by the WHO for the other countries for drug susceptible and drug resistant tuberculosis. And then we are having the quality medicines are there, all the parameters which need to be followed throughout the global and the other countries. All the parameters for the drug qualities are followed when we are supplying the medicine to the TB patients. And these medicines not only are available for the patients who have been identified and notified in the public sector, but they are available to the private sector also. It is 0.3 to 0.5 billion cases who are having this TB infection. Basically it is somewhere between 30 to 50 crores. And we need to tap these patients also before they develop the disease. So we are having this policy of the program meeting management of TB preventive treatment, where we want to give the treatment to these patients who are having bacteria inside them and they're not having the full-blown disease or before they develop the disease. We are having the certain groups and we are having certain priority remaining at the home most of the times, and they are exposed to the risk for the longer period. So these are the high priority groups of the TPT. Other than this, we are having the other family contacts of active TB cases in the family. Then we are having certain vulnerable populations like patients who are immunocompromised or are having on the corticosteroid or they are having some having chronic disease like or cancer patients are there. So these are the other vulnerable group where we want to provide this TPT. When we are having TPT, this PLHIV and the under 5 children, we are giving just after ruling out the active TB cases, and we need not to do the test to identify if TB infection is there or not, because we are having high prevalence of tuberculosis in India. But for other categories, we are having this diagnose and treat policy where we want to first confirm the TB infection in the patient and then we are giving the TPT. Able to do the justice to this TB program or NTB targets. Basically, there has been saying by our Honorable Prime Minister also, then whenever we want to achieve the bigger goal in the community or in the society, we want to have the this multi-sectoral approach, and everybody need to contribute to these programmatic settings from individual level to the organization. We are having this drug sale data and in the National TB program, and it has shown that the more than 117% patients are there in the private sector when we are comparing against this actual drug sale in the private sector. So it is a much more number of the TB patients are there. That is why it becomes very important, critical to have the private sector engagement, and definitely the corporate sector are the leaders which can set some of the examples for this to have the engagement in the private sector. Private sector, and this grey line is showing the contribution over the years from the private sector only. So you can understand like the contribution of the private sector is not coming as we want to have. Almost more than 50% need to contribute it from the private sector, but still it is the major chunk where we are having cases and they are either not being notified or not being treated properly. So we need to give the more focus for this private sector. And when we are having this, there is a large gap also between the estimate and actual patient who are being notified and treated in India. This particular cause, we have the National Health Policy which was framed in the 2017, and it is advocating the engagement with the private sector not only for the tuberculosis but for all the major public health problems. We are having our national strategic plan is also there for the tuberculosis elimination program, and it was developed between 2017, and it is having very focused approach how we have to engage the private sector. This we are having the guidelines for standard of TB care in India, so that we can have the proper and appropriate diagnostic and treatment. This partnership guidelines according to their contextual settings, and then we are having this PMJ scheme is there, where this is an insurance scheme, Pradhan Mantri Insurance Scheme, where a private sector hospitals may provide the services through this insurance scheme, and government of India is bearing the cost of that insurance schemes. And we are having IPACT scheme is there, where we are having the regulatory mandate also, that because a TB is a notifiable disease in India and there is a gazette notification, every TB patient, irrespective of it is diagnosed in the public sector or the private sector, it must and has to be notified. And we are having the legal provisions for this. We are having legal provisions for the drug sales also. If anybody is selling the medicine in the chemist or any outlet, then they have to keep every record of the drug sales, so that the government can know that how much of the medicines are being consumed in the private sector. And then we are having the price regulatory mechanism also, so that the anti-tuberculosis medicines are not having price, so that patients cannot afford in the patients. However, the program is of the TB patients, and basically it is advocated that intensified case finding may be started, and basically some screening of the symptomatic screening with this diagnostic facilities at earliest. That is one thing. We are having certain clinics and the certain vulnerable groups are there, like, and maybe put on the diagnostic test. Another request is that the NET is the priority investigation instead of microscopy. It need to be all the patients need to be provided this upfront NET testing is to be given. Then all the TB patients, if any services is needed from the program, they need to be linked with the NTP services. And definitely all the TB patients which are diagnosed need to be notified on the Nexus system. We need to provide the appropriate, correct and the complete treatment to all the diagnosed patients. So we are having the STC guidelines are there for this, and time to time at the national level and at the state level we are also having the CMEs with the private sector and the corporate hospitals, so that the capacity.
Thank you so much for inviting me to moderate this session. I feel privileged. Thank you so much. And now I call upon Dr. Bonali Datta.
Interesting to know, by the time we were starting TB control activities in 1995, the health-seeking behavior of the population. So at that time, we used to teach our students of TB, only 30% report self to the healthcare system with symptoms of TB. Rest would not come on their own to the healthcare system. And of the recently conducted national prevalence study, they similarly commented, after 1995 to again this survey which ended in 2021, and they say only 35% of the patients report to the healthcare with the TB symptoms. Rest remain in the community for long till they develop late disease or cavitatory disease, and then they are detected. So I think there is still that health-seeking behavior lacune on part of our population, which has contributed to this disease not being controlled. And on that front, something active needs to be done if we have that elimination vision in our sight. And on the context of that, this activity becomes very important because our health-seeking behavior is atrocious.
Which is highlighted in the first, and this is the more detailed map of Karnal, which has 6 blocks. Now of this, 3 blocks have been covered by us in this active case finding methodology starting from August 2022. And I'll present the results of these 3 blocks in the rest of the talk. So this is a randomized control trial, and as you can see, this is the map of Karnal, where the blue represents the control subcenters. The unit of intervention is the subcenter, and the red is the intervention unit. So in these 3 blocks, we have 52 intervention subcenters and 91 control subcenters covered over a period of 4.5 months or thereabouts to do door-to-door active case finding along with the ASHA workers. Next. And the subcenter is the unit of intervention, as I said, and this is our mobile van which is parked there. Now the thing to point out is that we used to do this activity for the last 7 years where our van would go to the PHC. PHC is a unit in primary healthcare services through the government in all the rural remote areas, which covers 30,000 population. That's too big. You cannot kind of close in that population. But the minute we zoned further into the sub-center, which covers 5 to 10,000 population, 2 to 3 villages, we realized this is the correct unit, because now you have the population that is kind of captive, that nobody slips through the net. So this is the model that we follow, wherein, as you can see, Barsat is the example of a sub-center where the van is parked. The van has a digital X-ray machine and CPNAT machine to do point-of-care diagnosis. The team, we have 10 teams on the ground on any day, and they go door to door. So 300 to 500 households are covered per day, 50 per team. And over a 9-day period, this particular area was covered. Next slide, please. So this is the cascade of the 3 blocks that we have covered. So households covered is 40,000, and the individuals of this, in these households are close to 2 lakh population. From these, based on the questionnaire, we have identified and then invited them to camps. They have undergone chest X-ray. We have now reverted, we have gone forward and engaged AI. Cure AI is a homegrown AI technology that has proven very effective and successful, and then gone on to doing CBNAT, and then the ones who are positive have gone to DOTS. We have further taken this forward to do contact tracing, because that is key. As everyone has mentioned, latent TB is not something that we can ignore. Got unique ID for the households, the geographic, the geocode, number of members, age, sex, and based on these points, they are invited to the camp. So we have successfully covered 94% of the total catchment area population, and some calculations done by Professor Al-Story shows that it takes us 44 rupees for each person for the door-to-door screening. So that is bound to be a cost-effective. Door-to-door active case finding, if it is done between 9 to 2 or 9 to 3, you will miss more than 50% of the individuals, because the men are away working, the children are in school, and you only come across the ladies of the household who are there. So very specifically, we did the active case finding screening, either early morning hours or in the evening or during the weekends, and that has resulted in us covering 94% of the people. But there'll still be some walk-ins who have to be reassessed, and after that the chest X-ray is done. So 3, 4, 5, 7 in the 3 blocks underwent chest X-ray. Cure AI was applied to this, and that divides it into 3 clear-cut groups: presumptive TB, abnormal not TB, and normal. Next slide, please. Use Gene Expert, and this, as you're aware, is a point-of-care test at field, in the field settings where it does not need sophisticated lab equipment nor training for the healthcare workers, basic training. So we've been doing it again. 2018, we first established one of these machines in the van, and we've been using it since then. The positives are always easy to deal with. Once positive, we hand over to the government, the STS and the lab technicians who are working closely with the team, and then they are notified and taken over for treatment. What happens to the negative? Because obviously we have seen these are so of the positive ones, as you can see, 129 came positive. These are a cohort that have to be actively followed up. You cannot say that, okay, X-ray is suggestive of TB, they are clinically symptomatic, but the CBNAT is negative and therefore we cannot do anything. So anyway, so we followed up with the second CBNAT 4 months down the line. So this was the first block where we were still doing clinical reporting. And after the first CBNAT showed 45 positive from a cohort of 156. What does D mean? It's a category of clinical reporting where they're strongly suspicious of tuberculosis. And in the second CBNAT that was subsequently done, 4 weeks down the line, 102 underwent it, 86 underwent it, for which 6 came positive, so a 7.5% pickup rate, and of these, 1 was DRTB. So certainly there is some merit in following up. Whether all of them need to have a second CBNAT, we don't have enough evidence yet, but these are patients who have to be, a close watch has to be kept on them. Whether in 4 weeks or 8 weeks, at some point they will present with symptoms, worsening symptoms and the CBNAT.
We have to go beyond that. And again, reiterating my slogan last year, go micro and go molecular. Both things are included in this study. That is door-to-door campaigning, house-to-house micro planning, and then doing CBNAT. And then providing X-ray and molecular testing, and following this X-ray positive by CBNAT 2. This similar finding was observed in the TB Free Haryana scheme also. They also told us that in asymptomatic cases, whenever they do CBNAT, it's of low yield. So this CBNAT in asymptomatic cases, that is upfront molecular testing, is a bit questionable, that we are learning. And then this role of AI. As a state of Haryana, I'm lucky to have 2 AI solutions, that is Cure as well as Mr. Harihar Chokos. We did a pilot study with Mr. Harihar also. In district Jeend. So we found as such, as per your findings, we also found that AI solutions led to early diagnosis as well as catching up those cases which are sputum negative. But because radiologist is not available in the periphery, so we could catch those cases also. So
and incidence is a pretty direct link. We also now understand further that there's a significant additionality to active case finding, and that it actually drives and improves passive presentation. And we're beginning to understand that we don't need to drive it all the way to zero. We're beginning to understand that there's a tipping point somewhere where the community force of infection reaches a point that starts to dramatically slow this epidemic. My colleague Chris Dye from WHO in year 2000 put forward the statement, shortened delay from onset of infectiousness at start of treatment to an average of 2 months equates to a 30% annual reduction in TB incidence. In theory, he is a modeler, but nevertheless the potential is there. Next slide, please. So we're going to take you on a journey of TB control amongst urban priority key populations. And this is a journey predominantly through our own lens in London and through the lens of the service that I run and clinically lead called Find and Treat. Next slide, please. I mean, in clinical medicine, it's an easy life. If you ask for a bucket, they'll give you a bucket. Next slide, please. But in public health, if you ask for a bucket, they'll give you a colander. And the entire thing will just leak, and you'll spend your entire life trying to plug these holes along any cascade of care and infectious disease you care to mention. But in tuberculosis in particular, tuberculosis is a real pain. As we know, it's slow and it's very complex. There are so many moving parts to the machine, and unless we think about it, it's quite a task. Nevertheless, we've been hammering away at TB control for many, many years. This is a photograph taken in Glasgow in Scotland in about 1959. And this one event led to a sustained decline in the incidence in the city, which had an incidence of almost 1% at the time, which is higher than Delhi is today. And this one mass mobile radiology screening event led to a dramatic reduction in incidence and a sustained reduction in incidence. Unfortunately, as the incidence declined in the general population, the detection rate went down, the cost effectiveness was deemed no longer viable, and this service was stopped in the UK. Many of our European partners were infinitely more intelligent, and they carried on screening, but they targeted it. It wasn't mass mobile radiology, it was targeted. Next slide, please. And here we see the Dutch fleet today. So, about 20 years ago, I borrowed one of these and stuck it on a ferry and brought it to London. Next slide, please. And we were able to demonstrate a significant prevalence of undetected active disease, particularly amongst the sort of high-risk populations, people in precarious housing, people on the streets, people who are struggling with addiction, etc. And we soldiered on, and we diagnosed and diagnosed and diagnosed. Next slide, please. And this was a process that I think demonstrates the importance of the marriage between the coalface, the clinical coalface, and research, because the only way we were able to sustain this program was through evidence on our impact as we went along. And I'm quickly going to hand over to my colleague Andrew, who's just going to take you through some of the nuggets.
Implementing program change of doing evaluation as you go along and trying to think about how you do that. I suppose that's what I've been trying to do. Al spends his life thinking about how to improve TB control. I spend a lot of my life helping him to think through about how to evaluate it. And these are just some of the examples of, first of all, finding out where the big problems are, which populations you're seeing your TB in at the highest risk, and then looking at the effectiveness of the different modes of active case finding. This, in particular, when we started doing the outreach programs, it was important for us to see that it was effective, and we could see that we were identifying people much earlier than they would normally be, much less likely to be infectious. It was reducing transmission, and we could show it was cost effective, and that helped us to get it into national guidance. Next slide, please. But I think the key thing after that is we realized that whilst we could find cases, we were seeing problems in the cascade of care. So we could find people, but then we'd lose them before they got into treatment. And also seeing people through to the end of treatment was problematic. So we needed more research there.
In sort of 2004, 2005, 53% of the cases were lost. So I'm just going to take you through quickly some of the things we've added to the programme over the years to plug some of these leaks in the colander. I mean, the first thing we put in was peers, local champions, people with lived experience, many of whom had had TB, some of whom had actually been found by the unit itself. And they were hugely effective in improving uptake and engagement with the intervention. Next thing we added, and again there's so many commonalities between the incredible work that Banali and colleagues have achieved in Haryana here. We added same-day diagnosis using the expert platform. In fact, I think we were one of the first to take it out as a mobile platform. Add to that same-day treatment initiation to hugely improve linkage to care, same-day case notification, essential for good surveillance, but also in the context of NICSHE, it's a phenomenal resource for clinical and public health follow-up as well. It is a great resource. Next slide, please. So we carried
my colleague, I found it very interesting and very impressive. So both Andrews and L stories, thank you. So these interventions, why we are talking today of active case finding, going into the community, into their house, knocking, looking for their symptoms and calling them and helping them out with the diagnosis, treatment and the support, letting them complete the treatment and whatever hurdle they face, supporting that also. So, these targets have come because we know that our community is not approaching the healthcare facilities, be it government or be it private, and it becomes quite late for them. And if we have to eradicate or eliminate TB, we reach out now. And the best thing for the program and the government public health sector is that the services are available. The resources are available, be it diagnostic, be it treatment, be it patient-friendly visit to their houses, everything is in place. Now we can afford to step out from our centers at the most peripheral level to their houses, call them and walk that last mile of care in TB services. And thereby only I think we can reach our target in India of elimination by 30 or 35 or 25, which our Prime Minister has challenged us with. So with this, and this academia giving us input that the active intervention does give you that additional yield to move at a faster pace to these targets and before the WHO or the UN targets. So thanks a lot, and I think this is the way ahead, and once we have set our house in order, we should take this lead into an active case finding and an intensified case finding.
To engage the corporate hospitals more systematically and scale that up to the other hospitals as well.
Thank you. Very wonderfully answered. I think the corporate hospitals have the necessary infrastructure, resources, the human resource, the financial resource, the expertise, the technology, and the standard of care. I think whatnot, they have everything. So I think very well answered, Dr. Bhavin.